Bam! Back at it again. Gatekeeper Season 2, Episode 2 with your host, Dr. Jeff Dykes and Dr. Brad Abicht. Joined
We're doing
tonight by a very special guest, Dr. Julio Ortiz. Brad, how are you doing tonight?
great, man. Good to see you. Good to see you, Julio. Hi, everybody. Thanks for joining us. Look for a good night.
Julio,
All
how
right.
you doing, my friend?
Good, brother. Good. Thanks for having me.
Absolutely. For anyone who doesn't know, Julio's a rock star. Big deal. But for anyone who doesn't know, they've been sleeping under a rock. Julio, tell them who you are.
I appreciate the intro. My name is Julio Ortiz. I practice in Boynton Beach, Florida. I've been in practice for almost 17 years, and I'm the director of the foot and ankle surgical residency at Bethesda Hospital East. I practice at Palm Beach Orthopedic Institute.
Awesome. Thank you so much for joining us tonight. Brad, what are we going to be talking about tonight?
Yeah, so a little bit different type of article tonight than what we've done in the past. Dr. Ortiz is going to lead us in reviewing this clinical consensus statement. I don't know if you can see it, but this one is from the American College of Foot and Ankle Surgeons, and it covers the appropriate clinical management of adult acquired flatfoot deformity. And Dr. Ortiz happens to be an expert in that, and that's why he was chosen to be on the panel. I will point out there's a number of other amazing foot and ankle minds on this paper. And I apologize to all of them and the people that we couldn't bring on, but it's just easier to bring one or two people on versus 16. So, or 15 is what was on this panel.
Yeah, the first 6 of them we asked said no, but Julio, you were top
Right.
10, dude. You were top 10.
Yeah. That works out great. Yeah, that's exactly probably what happened because I probably would be the last one on that list to invite. I was actually honored that there
Not
was some
true.
phenomenal physicians on that panel. So yeah, it was fun. It was a really fun time.
Yeah, I think we'll have an opportunity to get some of these other people that are on here for maybe some other papers and stuff. But I did want to not only cover the paper, but cover kind of the process behind the clinical consensus statements. And, I had an opportunity to be involved in one of these back in 2015 with the college, and it was on DVT prophylaxis, which is now probably outdated since it's been, a decade ago. We probably have more newer information, but yeah, I just wanted to cover a little bit of the process with this. And so a clinical consensus statement, just in case nobody knows, it's not supposed to represent clinical practice guidelines. It's also not a formal review of the literature, or it's not supposed to be relied upon for recommendations. It's supposed to recognize or reflect information, that is synthesized and organized by this panel of experts on the best evidence that we have regarding the topic. And it's typically topics that are fairly debatable, maybe topics we don't have a lot of like evidence or literature on. And so flatfoot is definitely a debatable topic. There's a lot of different ways to go about flat feet. And so I think that's really what this article strikes at is, some of the maybe dogma that's out there in the previous treatment strategies we've had for flat feet, at least back in 2020. But I'll also be interested to see from Dr. Ortiz kind of what has changed since 2020 because it has been 6 years, and I think we know a lot more even back than when this paper was published. So, what are you guys' thoughts on that?
Yeah, Julio, I want you to take us behind the scenes. Number one, how does it
Yeah.
come to be? How do they pick who gets to be on these things? And how many do they decide to pick on? I want to get a peek behind the curtain of how this comes to be.
Yeah, so this was actually an interesting time. I had been part of the college for many years. I was part of the consumer education committee, and so ultimately what happened is the board of directors decided they wanted to kind of replace the clinical practice guidelines that have been in place for many years, and essentially kind of come up with a consensus statement. So they reached out to multiple physicians that were noted to be specialists in flatfoot reconstruction, and I was fortunate to be picked to be part of the panel. And it was kind of it was interesting because it was a really kind of speedy process. We initially convened, agreed to be part of the panel. We had a Zoom meeting essentially early on, and part of the process was we selected some topics. It kind of subdivided the topics a little bit. So kind of part of the group focused on the pathophysiology of the disease, diagnostic criteria. The other part of the group focused on non-surgical treatment. And then some of us focused on the surgical treatment options. So, it was fortunately organized by the college and because if you've ever tried to get 15 surgeons on the same page, you guys know it's not the easiest thing to do. But we had a lot of support behind the scenes, and they organized everything. Essentially, picked a chair, and then we subdivided into a pediatric Flatfoot panel or subgroup and an adult Flatfoot group, and ultimately each of us were tasked with essentially scouring through the literature. We came up with some guidelines. Ultimately, we wanted to look at papers that were written within the last 25 years. We wanted, level 1 or 2 evidence if possible. But if it was a study that had, case studies, it had to have at least 20 patients. So we ultimately set some criteria and some boundaries to work within.
Yeah, go ahead, Jeff.
Yeah.
No, I was gonna say, what do we come away with that? So, we get these consensus statements, and like you said, you kind of stole my thunder, but I was gonna say, how I know this is a bunch of garbage is because it says the panel reached consensus. There is no flipping way you get 15 people in the same room and they reach a consensus on anything, ice cream, pizza toppings, anything. So,
Right.
I mean, how hard was it to come to a consensus on some of these things? I think you could maybe say yes or inconclusive or yes or maybe not strong evidence to support. But to say that there was a consensus, was there really a consensus that everyone is in agreement on these things? Because I think there's so much nuance behind Flatfoot in terms of diagnosis and treatment. And well, I use an Arizona brace. It seems to work for my patients. And
Yeah.
I never use an Arizona brace.
Right. Well, it was kind of essentially we broke it up in a way where it made it a little bit easier and more digestible. So it was kind of 2 surgeons at a time tackled one section of the topic, right? So the adult group, 2 of us tackled pathophysiology, 2 of us tackled the conservative or non-surgical treatment, and then 2 tackled the surgical treatment. So that's 6. Altogether, we had about 15. So the other side was the pediatric group, and they had a similar task. So we made it in a way where it's digestible. Each of us, each couple of surgeons, ultimately came up with 4 or 5 statements. And then when we all met in person in Chicago over a 2-day period, and then essentially threw out our statements into the group, right? So we all convened in a room and said, listen, this is the statement that I came up with after reviewing the 25 years worth of literature, and then we kicked out the statements that were absolutely not valid, and essentially came to a consensus that these 16 statements were statements that we could utilize to essentially give a little bit of a guideline. Not necessarily, it's not like a set in stone, this is how you treat it, but these are the things that, for the most part, the literature is supportive of, right? And that's ultimately where we went with it.
So that gives me a lot of clarity. Sorry, Brad, but I just wanted to say that gives me a lot of clarity. So these are the ones that you did come to consensus on, not
Right.
that you had these and you came to a consensus on all of these. That makes a lot of sense. So some of them were kicked out because you couldn't come to a consensus.
Correct. Yes, that's
Perfect.
exactly it. Yeah, there were some statements that just didn't get there.
Awesome.
Well, and just to be clear, like you mentioned, this was a quick process, and the paper says, this was over a period of 11 months. So, relatively quick, I guess, if you're publishing a document, but there's a lot of effort involved in these types of projects. And also, just to be clear on consensus, I mean, you guys came to a consensus on whether these statements were either appropriate or they were neither appropriate nor inappropriate. So,
Right.
if they fall into this neither appropriate nor inappropriate, it's kind of like, well, that's up to you as the surgeon to decide whether this is appropriate for your patient,
Yeah.
not what the necessarily the evidence is telling us right now. I think that's kind of important to point out. But then also, this is also graded based on evidence, right? So there's a certain method that you follow when doing these clinical consensus statements. And for those that care, it's the RAND UCLA appropriateness method,
Yeah.
user's manual. That's how the clinical consensus method is worked up. And this is sort of a modified version of it. And then you come up with these statements, and then the group decides whether it's appropriate, inappropriate, or neither. So that's what the consensus is on. It's not like, hey, every stage 2 Flatfoot gets treated this way, or every stage 3, like that's not the type of statements that were being made. And we can go into the
Right.
statements.
These were the statements that ultimately the adult group came up with, right? And part of the RAND UCLA process that we used was ultimately we threw these statements over to the pediatric subgroup, right? So Mike Theodoulou headed the sub headed our adult group, Jason Perano essentially oversaw everything. And to be honest with you, these guys did the majority of the heavy lifting. I participated a lot, and I appreciate you guys bringing me on, but these guys really did a lot of the heavy liftings, and they deserve a lot of the credit for this paper. But ultimately, we threw that to we came up with the statements, we threw it to the pediatric subgroup, and then they're the ones that ultimately classified it or graded it. 1 to 3 was considered inappropriate, 7 to 9 considered appropriate, and then anything that fell in the middle was neither appropriate nor inappropriate. And as you can tell, again, as Jeff said, it's hard to come to consensus, but these are the statements that we brought up, and then had the pediatric panel essentially grade the appropriateness of those statements.
Dr. Theodoulou is joining us. He's here in the chat with us. So thank you, Dr. Theodoulou, for joining us tonight, and as well as your work on this project. I do want to go ahead and read these consensus appropriate statements real quick, just for anybody who didn't get a chance to read the article. And then we're going to spin this off into some cases. We're going to use the article as a jumping off point to go through some cases. And Dr. Theodoulou, how we doing?
Oh, there he is.
Oh, all right. Yeah, this is great. These consensus statements were relatively new. So yeah, when we got this, Karen took over pediatrics. I took the adult. Jason kind of overarched all of us. And one, we didn't realize what a big bite of the apple we were trying to take with regards to addressing both pediatric and adult at the same time. You can imagine that's quite a subject, and to try to create consensus amongst the group. And then we had some initial misconception or confusion as to what we were doing. So, as I kind of mentioned in the chat, we actually created these statements and went more evidence based. We took it out of the context of surgeon experts and looked at literature and tried to create this ABC grade process. Is there evidence based to what we're saying, statements that are being made? And graded it that way. And so initially, and Jason and I were challenged by this a little bit, and we eventually evolved into making these consensus statements. So it was a process. It did take a fair amount of time to make sure that the group as a whole, their expert opinion was a big part of it, and not just the literature and the evidence when we made these statements and created these statements, and not go to a typical, okay, yeah, evidence points to grade level A, B, or no evidence to it. So that's kind of a little bit of the context and background on this a bit, so you guys can move forward with it.
Awesome.
Yeah. And I remember we actually talked about, I think we had extensive discussions. There were a lot more statements that we had originally come up with. And I think we weeded everything out a lot at that meeting in Chicago, just because we realized if we included everything, this would be like a 30-page article,
You guys had
Yeah.
16 final statements. How many do you think you started with? Like roughly ballpark. Do you think you got like 50 or something? Or
We were well over 30 between the two groups. We really tried to bring it down, and as Julio said, we tried to blind us a little bit by having the pediatric side review the adult and the adult review the pediatric. It became a really overwhelming process, and it did make us kind of bury into the snow like we are having up here right now, and kind of get stuck a little bit. And so that's when we evolved out of this, and let's say, okay, let's do something concise that the group can get together and just focused on the adult aspect of it. And that's how this kind of ended up. So, yeah.
Awesome. Thank you so much for hopping in and joining us. I do want to read those statements real quick. So it says obesity and equinus deformity both may contribute to the development of flatfoot, however, may not be the sole contributing factor. Spring ligament damage is an important component. I think we undervalue spring ligament. Can't forget about spring ligament. We'll focus on that in a little bit. Triplane correction should be considered when addressing flexible adult acquired flatfoot. Medial incision approach does not increased risk of complication. So a medial double does not increase the risk of complication when performing hindfoot fusion. So I think we'll focus on the positive. Brad, what do you think? And kind of, I don't know, do you want to go through any of the negatives? Because I do want to have time for all those cases that we want to talk through.
yeah, let's just start with this. All of those statements, everyone came to a consensus on, and they were grade B. So they were, level 2, level 3 studies. So pretty good evidence in terms of those statements. And I gotta say, I mean, I would agree with most of those statements from a personal standpoint and like the way I practice, I guess. And so, Julio, I don't know about you, if anything's changed since the time you guys did this paper, or if you would change any of those statements at this point, or not really.
I tell you, I think I agree as well. I mean, a lot of the statements, I kind of dusted off this paper. I hadn't looked at it for several years, and kind of read through it again over the last couple of weeks. And realistically, a lot of what is in here is pretty consistent with the way I practice. A lot of this literature was, even though it was some of it 20, 25 years old. I think some of it, and I think ultimately, well, because of the fact that these were the statements that we came up with after sorting through the literature, and this is what we picked to be valid at that time. And I think most of it is still valid, to be honest with you.
Dr. Theodoulou, if you had to summarize this in one statement, do you think there's one that's either undervalued? I kind of gave away my answer a second ago. Do you think there's one statement that's undervalued, people forget about, or that stood out to you as kind of the most important thing to take away from this paper?
Yeah, and it's kind of funny because I'll briefly state I was asked to present this at a recent, I don't remember which ASC it was at. Maybe it was down in New Orleans. But as just at the time that our orthopedic foot and ankle guys came up with the progressive collapsed foot deformity and looking at their evolution and appreciation of this condition. But at the end of the day, I truly believe this to be an instability of the foot. This is not a progression of a pediatric to an adolescent to adult flat foot congenital. This is an instability. And so the deltoid ligament is my biggest take home as it's the failure of the deltoid ligament for whatever reason that's causing this progressive subluxation of the mid-tarsal, what I call the pedal acetabulum, that allows for the collapse of the foot. And so I think the big take home is the deltoid is the key to this process. So.
Yeah, I have to
So
agree. I mean, I think in my practice, I find pediatric and adult flat foot essentially two almost completely different things, and I don't generally treat them both the same way, and I try to train my residents that way to kind of look at ultimately where is the fault, where is the deficiency, and not every single one of these is the same. They all have different etiology sometimes.
not that the exact terminology matters, but back in this paper, we were using adult acquired flat foot deformity, posterior tibial tendon dysfunction, flat foot, pes plano valgus, pes valgus. And now, more recently, we have progressive collapsing foot deformity. What are you guys using in your practice these days, or like just day to day talk? I mean, are we using this progressive collapsing foot deformity when you're describing this to your colleagues and talking to your residents or whoever you might be, you know, conversing with this?
For me personally, yeah, I've evolved into the PCFD. And when I write for orthotics or bracing, it's PCFD, and I'll say supple or rigid, one or two, ABCD, ankle involvement. I've kind of evolved because it really is that conceptually is really the problem. It is a progressive collapse of the foot due to instability and failure of the deltoid complex, with subsequent then ultimately potentially deficiency tendinopathy of the posterior tibial tendon and that whole progressive process. So in my current vocabulary, I've adopted PCFD and have gone away from, what historically we've talked about the acquired adult flat foot. Does that really change my treatment protocol and my approach to it? Probably not. I still look at supple and rigid. I look for arthrosis. I look for all the extent and deformity, apices of deformity. So it really hasn't changed. But from the standpoint of communication, I've kind of fallen into that literature. I mean, to that linguistics, so to speak.
Just a quick follow up on that because I have a case that might fall into this. So let's say you have a rigid flat foot, you're doing either a double or a triple arthrodesis. Are you
Mm.
then also repairing the deltoid at that same time, even if the ankle does not have a valgus deformity to it? Are you just making sure the heel's under the leg and you get a good anatomic reduction of your subtalar TN joint? Like, so
Yeah.
that deltoid is one thing I worry about when you do a double or a triple. And I've been burned by this, where down the road, I see that patient in 10 years, and all of a sudden now they got a valgus ankle because the deltoid gave out. How do you
Yeah.
address
I
that?
think that,
Yeah.
yeah, no, go ahead. You guys can talk. Yeah,
And
but
I think a lot
absolutely.
of people forget. A lot of people forget that the deltoid's a component of the deltoid, or the spring ligament's a component of the deltoid ligament, right? So it's essentially a continuation. And unless you address that, I think ultimately you can end up with ankle valgus. And I've seen it happen. I've had patients where they get a triple. Next thing you know, their ankle's going into valgus. And what was a triple ends up being a, pantalar.
That goes into what Nemesis is talking about, even in dealing with ankle fractures, evaluation of the deltoid. Not so much as you're creating really stability across the ankle mortise, you're actually preventing the future Flatfoot, is what he's doing it. So when he's repairing the deltoid on his unstable ankle fractures, bimal, trimal, it's not because he's trying to directly necessarily repair that and create stability of the mortise, because we can achieve that through a syndesmotic approach, is because he's trying to prevent a future flat foot. And I agree. I can't tell you, and you guys have probably seen it, how many sequelae to ankle fractures that we've seen, trimal, bimal, that go into a progressive valgus of the foot. And you see them down the road. I've had more than my share of those. So
Yeah.
I think it goes both ways.
Mike, how much of that do you think is related to neglected deltoid injury? And how much of it do you think that there was a structural deformity?
I think in a post-traumatic situation, in an ankle fracture, I think it's a huge part. And this, and ultimately, we look at our ankle repairs and we think we do brilliant anatomic, and we're going down a different rabbit hole. But
Right, sure.
I think it's all it's all part of it. And I think we see so much subsequent end-stage ankle arthritis because we're not rebalancing the foot and repairing the injury of those ligamentous structures that occur. And so that's why even the greatest context of how we repair these ankle fractures structurally and skeletally, if we're not repairing the associated ligamentous injuries, this is where we see the progression, the valgus, the subsequent development of arthrosis. I think it all goes hand in hand, personally.
Yeah, no, I agree. I mean, and not to go off the rails, but we've started to look at that a little bit at our institution. I've started to, and I've got one of my residents working on it, but ultimately we've started to MRI a lot of our patients with ankle injuries. And a lot of them, not only are we finding that there's deltoid injury, but at least 15 to 20% of them have posterior tibial tendon injury. And I think we've all seen it. You go in, you fix an ankle fracture, and then months later, you find out the patient had posterior tibial tendon tear, right? So I think a lot of that medial ankle instability can, if not addressed, can lead to systemic issues down the road.
Brad, you want to go ahead and jump into your case, and we'll use that as a talking point for some of this other stuff and circle back with all the analysis? Because I think some of the younger people
Absolutely.
listening want to hear our breakdown from here's a case, how are we evaluating it, how are we working them up, and how are you choosing the procedures? That was a thing that I struggled with for such a long time. Hey, look, they got a flat foot. Oh yeah, I can see that clear as day. That's like early school. But then they're like, well, what procedures? You're going to do an Evans, you're going to do a Cotton, you're going to do a calc slide, you're going to do a triple, a double, a what? You're like, oh, I don't know. Why? Which one do I do what on? So you want to throw your case up?
Yeah, and this is a great lead way into that, because under the section of neither appropriate nor inappropriate, one of the last statements was rigid flat foot deformity may be effectively treated by talonavicular joint and subtalar joint fusion in combination or isolation. So keep that in mind when you're looking at my case. I'll see if I can share my screen here. All right, can you guys see the screen?
Yeah.
Yep.
All right, so here's the case. 66-year-old female. She's had a progressive flat foot deformity. She has medial ankle pain. She has sinus tarsi pain. In the clinic, in weight bearing stance, her heel is in valgus. It is rigid. There's maybe a little movement there, but it's majority of it is rigid. She also has a symptomatic bunion that she kind of asked me about last minute too to throw on. That's always dangerous. We'll focus mostly on the flat foot here. She is a half a pack a day smoker,
No,
and
she's not.
history of
No one quits at half a pack.
I'm just telling you what the chart says, Jeff. Obviously, that means she smokes more than that. So she's got a history of breast cancer, but not currently being like actively treated. And, this was over a year ago. So these are her weight bearing x rays. And, I do not have a weight bearing CT modality available to me. I'd love to. And that's one thing that some of the newer literature, focuses on. But these are her weight bearing x rays. And she's kind of got that smoker bone appearance. If you look at her osseous structures, not necessarily the worst DJD you've seen, but a little bit of narrowing, I think, there, and some rigidness to those joints. This
Brad,
is what her foot. Oh yeah,
And
sorry.
I don't mean to
Right.
interject, but one of the things that I kind of wanted to highlight here that you did, which I love, is you got this long leg axial. I've started, obviously it's not always available, but when you have it, it's so, in my mind, it's so helpful because you could see that calcaneus is all the way out there valgus. You know what I mean? It's nowhere close to aligned to the tibia.
I'm a huge fan of that view, and I
Yeah.
do get that regularly on most all my ankle views, and so yeah, it can trick you a little bit, especially when your rad techs don't put the foot in the right position. But for the most part, I think this is a very helpful view in flat foot deformity.
Yeah. No, I didn't
I'll
want to cut
point,
in into your
yeah, no,
conversation here, but that's huge.
yeah.
I love that.
I'll point out though, those who can't get a Saltzman view, which is what this is, and who can get a long leg oscalcis view, if it's done appropriately, actually both studies are reproducible to assess the abduction of the calcaneus from underneath the tibia, because you do have to have appropriate positioner to get a good Saltzman view, where long leg oscalcis is much more for us in a hospital system where we don't have that all the time. Neither here nor there, but yeah, that shows the appropriate abduction of the calcaneus from underneath the tibia. So that's a beautiful view.
Yeah.
All right, so these are non-weight bearing, obviously, but this is just what her foot looks like. She doesn't have the greatest skin. She actually had a laceration on her finger that took months to heal, and, and there was a picture of it in her chart, and it kind of freaked me out because I was like, wow, if that takes a long time to heal, this is going to be a problem if I'm doing a double or a triple or what, some calcosteotomy or whatever we're going to do here. But I guess I'll pause there and see just what you guys kind of think so far, or what you might be thinking you'd do for a surgical procedure.
Her ankle is rectus. Her ankle
Yes,
is
I didn't show you all her ankle views, but her ankle mortise is great. No valgus deformity there. Everything's neutral.
Did you get an MRI on her?
I did.
You said it. I don't know if I heard it or not.
So Julio, that's great, because didn't we review indications whether or not MRI does any difference as to your treatment plan for a patient? And I think
Right.
we did not come to, I don't think we came to consensus with that. I'll be
No,
frank with
no.
you. I seldom order MRIs for these unless I think that I'm looking for other pathology, some other disease process.
Yeah.
I don't see value in them. That's just me, because I'm going to treat
Yeah.
what I'm going to treat, and it's either supple or rigid. Um,
Right.
and and if you talk to a lot of people, where is the failure of this? Where is the true failure? This is the talus subluxing off the calcaneus,
Mhm.
and you
Right.
don't have the sufficiency of the deltoid complex supporting the talus. What's the best way to stabilize an unstable joint, which is what this is, subtalar instability because of deltoid insufficiency?
You've got to fuse
Would
it.
be
Yeah. Yeah.
fuse it. I mean,
Yeah.
if you
Yeah.
talk to Mark Hardy, that's exactly, or even Luke Ciccinelli, that's like one of their favorite procedures for this is an isolated subtalar joint fusion with whatever else you may need to do periarticular to this, because you're going to create that talus that'll sit fixed onto your calcaneus.
Right.
Um,
Yeah.
Absolutely.
I'll be honest with you. Over the years, I like to have more documentation than less, to be honest with you. So I get the MRI, not necessarily to look for for the tendon. I'm looking at the subtalar joint. I want to see if there's subchondral sclerosis. I want to see if there's arthritic changes in that TN joint. And those are the things that I'm looking for. Most of the time, it's depending on how heavy they are, I'm going to think of fusion anyway. But even if I've got someone light, a little bit smaller, there's not that, it doesn't look that bad. But then I got an MRI and there's tons of subchondral sclerosis and we've already got some arthritic changes there. That for me is going to be the certainty I need to fuse it.
I'll tell you where an MRI comes into play for me a little bit is in the supple deformity, where
Yeah.
I'm looking to do an FDL transfer. I may do some other tendon rebalancing, so I want to see the girth, the strength, because I'll get it up the leg to actually see muscle
Yeah.
hypertrophy what I have from the standpoint of doing any tendon transfer. That's
Yeah.
where in the supple.
I just gotten burned on those that are supple, and I do the reconstruction, and then inevitably they got a perfectly straight foot, but they're still painful in the subtalar joint, and I somehow missed a subtalar joint that was arthritic. So I got burned early on in my career, and then I just I rather get more information than less these days.
I will tell you, I got the MRI. It did not change what I ultimately did for her. Jeff, would you do anything other than a fusion in this situation?
no, but I would lean to MIS if she's a half pack smoker. If she's a half pack smoker and she had a finger that took forever and a day to heal, I'd consider MIS double. But my thing that I would throw back to you is sometimes I do a double and I've been a little unhappy with the calcaneal cuboid joint. And so one thing that I think is a little bit helpful is, well, what I don't want to step on your what I'm going to save my comments. I'm going to show me what you did and then I'll tell you why you did it wrong.
Well, it's too late, Jeff, because that's exactly what I did. So I did an MIS subtalar and TN arthrodesis, and then we did an MIS bunionectomy to throw
Damn
that
it.
in
I
there.
can't tell you what you did wrong if you chose that then. Okay.
Well, so here's intraoperative. I approached this through a sinus tarsi, percutaneous incision, got our burr in there, took out the subtalar joint, and then similarly through a anterior medial portal, accessed the talonavicular joint. Once both joints were prepared, like Dr. Theodoulou astutely said, the talus is falling off the calc. You got to get that thing back up where it's supposed to be.
Yeah.
And so that's the first thing that we did was secure that on the subtalar joint. And if I'm fusing the TN joint, I generally will use mostly just one screw for the subtalar joint because I know the TN is going to be held securely as well. And then for the TN, it's kind of dealer's choice, but I had two compression screws here, and then I added a third just for more rigidity. And then there's her MIS bunion as well. I try and check a calc axial intraoperatively, but hopefully you can see like now the talar head is covered by the navicular. You can see a little bit of that talar head above the navicular on the lateral view. The talus is back on top of the calcaneus. And so hopefully, if these things stay where they are, we'll have a successful outcome. And then here's her percutaneous incisions, and hopefully she won't have any wound complications or infection or anything like that. Now, I show this case mainly because, this document really does not talk about MIS at all. And you guys know I'm a big MIS guy. So I don't know how MIS would really change any of these statements or any of that, but I'd be interested to hear you guys' thoughts.
Well, one, I would say, Brad, you're an amazing, and Jeff, I've got this work. I can't, Julio's much maybe more old school like me. You guys do
Right.
amazing percutaneous
Yeah.
MIS work, so I caution people seeing this that unless you have that level of expertise, because joint prep is absolutely critical for fusion. If you get pseudarthrosis, you're not helping anyone, you're only open. So on, you've got to qualify that too. I will say in a majority of these cases, a big pain generator in this is the posterior tibial tendon itself and its tendinopathy. So I frequently will cut out the posterior tibial tendon because it can remain as a pain generator after fusion. And so as long as I'm fusing this and it's not providing any function, I consider that a pain generator. And the only way I can do that is through open excision of that. So a pain generator with soft tissue is important that you can't achieve with MIS. You've got to be very good at it like you do. And the only other thing we didn't talk about, maybe we'll touch on this, is posterior leg muscle lengthening, equinus addressing when you do it and when you don't. And I will tell you, I presented at ACFES. My last procedure is the equinus. I do the reconstruction because I'll tell you now more than 80% of the time, I don't even touch the posterior leg muscle group when I do a flat foot reconstruction because once I get it realigned, the equinus doesn't seem to be an issue with it anymore. So that's a kind of a side thing, so to speak.
Yeah,
But
I address it a little bit less these days as well because the way I think about it, I kind of think about the calcaneus almost like the 50-yard line. You want to get it either on one side or the other side of that 50-yard line. And a lot of times when we're lengthening, we're trying to kind of overcome that pull of the Achilles. But if I can get that calcaneus in a more varus attitude, I often would rather the Achilles tendon kind of help pull the calcaneus into a little bit more varus if I can. So I've gone to doing it a little bit less, just like Mike said. Now I want to play devil's advocate here a little bit, Brad. What do you
Sorry,
do?
that's all the time we have tonight.
Yeah.
So we're gonna wrap. No, I'm just kidding. Go ahead.
So what do you do? So one of the things that we've been looking at is a lot of times when I'm doing these, still I'm a little bit more old school. I open these up, but when I'm doing them, I'm putting a posterior lateral wedge in the calcaneus to kind of help in the subtalar joint to bring that calcaneus into a more varus position when I'm doing my subtalar joint fusion. What do you do when you're doing your MIS? Do you do anything to try to kind of wedge that joint a little bit? Because obviously the joints in a, and we know structurally when we look at the studies that the joint does alter over time. So what I found when I'm doing these open is that I need to do something to overcompensate for that, especially when I'm fusing the subtalar joint. So I do put a posterior lateral kind of angled wedge to bring that heel into a more rectus position and kind of realign my angles. What do you do when you're doing MIS? Do you do anything to compensate for that?
I've done things like that where I'll either with the burr, take a wedge out to correct the deformity or try and pack the majority of my graft on one side of the joint to possibly help with that. Now, I think it gets a little more difficult when you're trying to address lengthening or like the CC joint because in general, I have to use some kind of structural graft for that. And you can get a metallic wedge or a structural graft in with a pretty small incision, but it's not quite percutaneous. So that gets a little more difficult.
Yeah.
That's what I was gonna say is two things. So for any of the younger people absorbing this information, ignore the bunion for a minute. The MIS is garbage anyways. We'll ignore that. But let's focus on that.
Jeff would have done a Lapidus for sure.
No, but that brings up a good point. Like why would you or when would you consider like a cotton let's say we're going to stage this out. Normally we went
Right.
from posterior to anterior. We're starting the hind foot. So we see if we can get our correction and then work our way forward. At what point would you consider adding a distraction calcaneocuboid joint arthrodesis that acts almost like an Evans, right? Think about what an Evans does, and you're going to distract that and have little additional correction with your distraction CC joint arthrodesis, or adding in any kind of midfoot procedure. Again, not in this one because it's got a bunion, but what about adding a cotton? Brad, what are you looking at either intraoperatively or do you consent them for fusions and osteotomies as needed? Or what do you have a pretty set game plan when you're going into this before surgery?
So this particular case, she was consented for a cotton, just in case, but at the same time, she wanted her bunion fixed. So in some of these MIS bunions, you can translate the head plantarly, and it'll give you somewhat of a cotton or lapidus or a lapicotton type effect. And I apologize, I don't have the lateral view here of the head, but I did move it down a little bit as well. It wasn't dramatic, I would say, as much as probably a cotton or even a lapidus properly done. But you can do that with these MIS bunions as well. And for me, this is a quick thing. It's easier. It's just, I've done hundreds of these things. So it's easy for me to cut the head, move it down, and get that type of effect. Now, other people, they might prefer the cotton or doing a lapidus just in general. But that was my reasoning, I guess.
How often do you see CC? That's too many C's. How often do you see CC joint arthritis after, or you uncover something? It's impacted because they have lateral abduction of the forefoot on the hind foot, so that's impacting at the calcaneocuboid joint. So some of this disimpacts it and distracts it, so it's probably not painful. How often do they come back in later and say, well, it still hurts over here?
Yeah. So for me, sorry,
No, go ahead.
yeah. So for me, I'm still a huge advocate of triples. I know people have gone more to doing doubles, but I still do a triple. And exactly for that reason. Because what I found is when I line up my TN joint, when I line up my subtalar joint, my CC joint inevitably will gap, right? So what I want is I don't want that foot to ever want to go back into a valgus position. And I want to protect my hardware primarily along the TN joint, which is sometimes a little bit more difficult to fuse. So I almost always put an interpositional graft in that CC joint. I'll prep the joint and I'll put a wedge in the CC joint almost every single time. And for me, it's kind of like a kickstand. It prevents the foot from even having the ability to go more into valgus. That's why I still do triples because I don't want to protect my hardware. And that interpositional graft, in my mind, does that.
Mike, do you have any
I will
strong
see.
thoughts? Double versus triple?
Yeah, yeah, I've gone both ways, and it really depends. The interesting thing about talking about any acquired forefoot supinatus, when you're evaluating these patients preoperatively and you're putting that hind foot into neutral if you can, or even if you can't, and you have a forefoot supinatus, if that's sitting over 10 degrees of supinatus, you're never going to get any medial column plantar flexing procedure that will get it out of that type of varus. You got to go to the TN joint. And generally, I'll evert it through the mid-tarsal complex, bring the forefoot, medial forefoot down, and fuse the tailonnavicular joint as you are. So that addresses any supinatus or varus of the forefoot, and you really don't have to do anything plantar flexing. When you do have to consider that, though, is again, if you're dealing with a flexible deformity and you're being reconstructive about it, then bringing that medial column down, that first ray to protect whatever you've done to the hindfoot is absolutely critical, whether you're doing it through a fusion of a lapidus or a cotton procedure. But if you're fusing, doing a medial double like this, yeah, I'll just, I'll pronate it through the mid-tarsal joint, bring that first ray down through that and fuse it at that point. The only other thing, and Glenn Weinrob talks about this too, is some revisions that we do, I will do an Evans or lateral calcaneal lengthening osteotomy to help bring that back into adduction. We get a fair amount of revision cases where people are still in abduction. You've got to take things down, and doing that Evans can help quite a bit in restoring the triplanar correction and getting it out of abduction and helping you with your medial column work. So that's the only thing.
Absolutely. Let's jump ahead to a couple of Julio's cases here. We'll see what we have time for. And if anyone has any questions, throw them into the chat or the question and answer. I can check both those. So if anyone has any questions, throw those in there as we go along here. All right, Julio, you want to take us through this since it's your case? You know more about it than I do.
Yeah, absolutely. This is a case I did an MIS procedure on. No, just kidding.
This looks very similar, I gotta say.
No, this is a 39-year-old patient. I'm still very much a traditionalist. She came in, and to be honest with you, if you look at that lateral X-ray, she doesn't look that horrible. But this is one of those cases where I did a posterior tibial tendon. Sorry, I did an MRI and it did show a lot of tendinopathy in the posterior tibial tendon. Her main issue was a lot of medial arch pain, and then obviously that bunion deformity that was causing her a lot of trouble. We did a kidney on her, calc slide. I went a double osteotomy on her, and then once I did the lapidus, I used the lapidus ultimately as a kind of lappy cotton. And what I always test the intercuneiform joint. I noticed some instability there, and then I kind of threw that first to second screw. They On her, I did a lateral, a double calcaneal osteotomy. So I do my calc slides with the giggly saw. Larry D. Domenico wrote a great paper on it a few years ago and kind of convinced me to start doing it that way. So I started doing that, and you can see there's a partially threaded screw across the calc slide, and then that fully threaded screw is across my Evans. But I was able to kind of restore my calcaneal height. She was really happy and actually came back about 4 years later to have the other foot done, and that's that second case I showed you.
So I want to
Uh,
go back for a second. So
yeah.
anybody looking at this X-ray, how did you come to the conclusion or procedure selection? Because if you have an entire buffet of delicious food in front of you, you want to eat it all. How do you pick and choose what you? That's not a very good analogy. I'm gonna
Really?
edit.
Jeff, what was
I'm gonna
that?
edit that out. It
So
sounded good in my head, and then it didn't land. All right.
I always start proximal to distal or posterior to anterior. So I did do a gastroc recession on her, and then I don't have the long leg axial there, but her calcaneus was in a little bit of valgus. So we did the Evans first. I didn't get enough correction from that, so I did my calc slide, and then kind of the way I look at the Evans or the cotton or the lapidus is ultimately I need to get that leg of that other leg of the table down. Once I did my rear foot procedures, she was in a lot of forefoot varus. So I was able to at least bring that first ray down sufficiently where it stabilized the foot and prevented that kind of retrograde stress on the rear foot.
So, what are your thoughts on the spring ligament? Says you got an MRI, spring ligament rupture. Do you think the spring ligament is it the chicken or the egg? Did the spring ligament insufficiency lead to flatfoot medial arch pain, or did the progressive collapse lead to insufficiency and subsequent tearing of the spring ligament? Point of that is, do you repair the spring ligament, or by reconstructing the arch, the ligament is not under the same amount of stress and you don't actually need to repair it? Thoughts?
I think it's a combination. I think we need to not only address the bony deformity, but address the soft tissue deformity. So I have started doing a little bit more spring ligament repair. I've done it several different ways, and kind of have adopted newer ways over the last few years. But I have
When you say
Started
newer, do you mean suture anchor very?
feature anchors, different types of bracing material, suture versus biologic bracing material. We don't want to use any specific names, but
I got you.
yeah, but ultimately, I've gone to at least addressing it. If I'm doing tendon balancing or trying to kind of periarticular osteotomies to try to address the joint.
Mike, do you have any thoughts on spring ligament repair, or will it solve itself if you correct the osseous problems?
Yeah, it's a great question. One, I think it is a problem of the spring ligament. I think in a lot of our patients, particularly women, we get myxoid degeneration of this connective tissue that gradually begins to fail. And then we start seeing the collapse as we have the instability across that complex, as we talked about. If I'm doing if you talk, I had a great pleasure to argue against Larry Domenico, since you guys brought him up, where he presented that you don't need to do any soft tissue reconstruction. It's all osseous. No soft tissue reconstruction is warranted. And I presented the other side. No, you need to do soft tissue reconstruction. I think it really depends on the patient. Everyone's uniquely different. Interestingly, I do a fair amount of peroneus brevis to longus transfers and a flexible flat foot. The reason I do that is because I take away the deforming force of the brevis, which has begun to overpower. The reason why we use the FDL, it's nowhere near the strength of the posterior tibial tendon. In fact, if you really want to kind of match it, most commonly it would be an FHL versus an FDL transfer if you really want to counteract that. But we use the FDL because it's readily available. It kind of balances that. But the peroneus brevis can still be a deforming presentation. And if you want to address that, take the brevis away, attach it to the longus. It'll plantar flex the first rate, create your lapicotin, and you get your FDL transfer and whatever else you're doing through the hindfoot and basically reconstruct kind of indirectly that whole periarticular subluxation of the deltoid. Now I'll go ahead many times and cut out a portion of the deltoid, reef it up, and then do that as part and imbricate that as part of my FDL reconstruction. There's lots of ways to approach it. So, but in a flexible deformity, yes, I address all the soft tissue. In a more rigid, or if I'm going to just fuse it, I just fuse it and let the osseous correction take care of it.
Sure. Makes sense. Julio, for anyone who doesn't understand what we're looking at here, it looks like you put 3 screws in the first metatarsal and 3 screws in the cuneiform.
Yeah, so that's the newer case, and I've gone to using carbon fiber plating for those. So that's a carbon fiber plate across the lapidus fusion site, which I've really enjoy because I can actually see the joint fusing through the plate.
Yeah, so anyone not understanding that, the carbon fiber plate itself is radiolucent and you
Yeah,
can't see the actual plate, you can only see the screw. So looks like Julio's terrible. Looks like he doesn't know what the hell he's doing.
yeah,
But
I completely missed.
all right, let's go to this second case here. We got a little bit of time left.
Yeah, so this is another case. This is a lady I'd known for years. I had actually, and this highlights kind of what I talked about previously. Is this is a patient who I did. She was supple. She had a complete rupture of the posterior tibial tendon on the contralateral foot. And I did a PT tendon repair, FDL transfer, all the soft tissue work, some augmented osseous procedures, periarticular procedures to kind of repair her. And she did well, but unfortunately for years, I was addressing some of her subtalar joint arthritic changes that were essentially neglected because of the Flatfoot reconstruction. So in this case, I kind of learned from the first one, and we addressed it with the rear foot triple. Again, in this case, she also had a lot of degenerative changes at the first MPJ, some arthritic changes at the first metatarsal sess1 articulation, as you guys have kind of heard me talk about before. I always want to look at that, and so we went ahead and did a standard triple arthrodesis on her, and I did a first MPJ fusion on her as well.
What's your determining factor? So on the first 2 cases, we're doing reconstruction. And on this second case, we're doing fusions. For any of the younger people, what are you looking at either clinically or radiographically? What tests are you doing in the office? What's helping you actually decide which procedures that you're going to select?
Sure. Yeah. So again, as I mentioned, I always do an MRI on these patients. I want to see the pathology, both osseous and soft tissue. So in her, there was complete degeneration of the subtalar or the deltoid ligament, advanced talonavicular subtalar joint arthritic changes. So for me, there was no question she needed a triple. Additionally, I'll give him a subtalar joint injection, a numbing injection, have him walk around. And she had a lot of pain in that subtalar joint. So again, that kind of reinforced my decision making process. And then if you want to kind of talk about the first MPJ, but obviously I've got a really low threshold for those. If there's arthritic changes there, that for me is one of the most reproducible procedures. So I do a lot of those.
Julio, maybe I missed this, but did you say you did anything with the deltoid surgically, or it was just noted on MRI that it was
On MRI, it
degenerated?
was complete. Yeah, there was complete degeneration of the deltoid ligament. But at that point, I fused the sub. I brought the. You can't really see it there, but I did same thing. I wedged her subtalar joint to bring her calcaneus into a little bit of more varus attitude. I didn't. I didn't get a chance to give you guys the talc axials, but so I was able to get the calcaneus in a little bit better alignment. Once I fused that the talar joint, I didn't necessarily do much to augment the deltoid. And like I said, over the years, I've started to do a little bit more of that. But this case was probably about 8 years ago, so I didn't really do anything at that point.
But now
So
I've
this
seen
goes
both. Go ahead, Brett.
this this goes back to my original question, right? Like, so you did a triple, and on the MRI, it showed some deltoid changes. Like in these situations, should we be doing like a medial brostrum, reinforcing or augmenting the deltoid ligament? I know you wedged the subtalar joint, try and
Right.
change the axis a little bit and
Yeah.
protect the ankle, but over time, this is the thing that for me, I worry about, and it's going to come back and burn me in the future. And then now we got to address that. And yeah, I don't know what the right answer is. I'm just posing these questions, I guess.
No, you're absolutely right. I mean, and that's why I've started to kind of look at that a little bit more because I have seen these patients come back with a little bit more. They'll come in and they'll go into a little bit of high or ankle valgus, and I don't know if it's that we've neglected the deltoid or that we haven't gotten the calcaneus in an appropriate position. I think putting the calcaneus in a more rectus position, kind of lining up the mechanical and anatomical axis of the leg, of the foot under the leg, I think makes a huge difference, right? So I don't know if it's that or if it's that we're neglecting the deltoid. I don't know. What do you think about? What do you
Well,
think,
just
Mike?
just additionally, like superstructurally, some of these people are obese. They have
Right.
knee or hip problems. So some of it can be coming from higher up, not just
Yeah.
at the level of the foot or the ankle. So I think you got to kind of look at that too and throw that into the equation.
Yeah.
Because I don't know
That's
that,
why I mentioned the long
beefing
leg
up the
axial.
deltoid,
Yeah, but
beefing up the, oh,
I'll suggest how many times have we had a planned stage triple tar or double tar? You stabilize the hind foot and they never need the tar because it takes the symptoms away from the ankle. You look at that kinetic chain and see how things are working up. In these cases, it's really about the native tissue. Can you rely on the native tissue to support any reconstruction that you're doing? If you can't really rely on that native tissue, then fusing, and with Julio right here, you don't have the native tissue to support a reconstruction. Now, your question is great in the sense, Brett, do we have studies? And maybe this is what we need to study. What is the upstream mechanics and kinetics that would drive a fusion of the hindfoot to cause increasing insufficiency, or if there is an insufficient deltoid to produce a valgus ankle. And I don't think we've really studied that. I don't think we have any great literature on that. We look at it anecdotally and maybe we extrapolate from some of the stuff we do, like I said, triple tar, or, or even, arthrodesis of ankle and what its downstream mechanics are to the hindfoot complex, but we don't really have any great validated studies looking at that. So maybe that's what we should look at.
Yeah, and
Are
I think
these?
it's
Go
too
ahead.
easy to pigeonhole ourselves, right? We look at the condition in itself and often don't look at it from, kind of a 10-foot level, right? And so that's one of the things I always try to encourage my residents to do is don't just look at the bunion, look at what's causing the bunion. Don't look at the flat foot, but look at the entire leg and what are the mechanics that are leading to it, right? And I think that's part of what the study also showed, when we talked about Aquinas not being a sole driver for Flatfoot. When we talked about some of the other things not being sole drivers, obesity being a contributing factor, but not the sole factor, right? So that's
Yeah.
kind of, I think, part of what we're trying to get at with some of those statements from the article, just kind of to bring it back to the article.
Yeah, I've started doing a minimally invasive deltoid repair. It takes about 5 minutes. So if we're on the fence, I mean, for an extra 5 minutes to suture down and anchor down the deltoid, I don't know if anyone's described that before. If not, I'll write it up and describe the technique. But it's very simple: just one anchor in the medial mal, one anchor in the talar body, and they're tensionable anchors, so you can get your correction. It's
Yeah.
pretty straightforward. So
Right, you're doing deep then, Jeff. You're not, it's not just superficial. You're doing the deep in that regard.
correct.
And so is the deep truly a component of the extension to the spring ligament? I mean, that's the question. I know you're holding the talus in rigidly. I mean,
Mhm.
you are, but is it truly an extension to the spring ligament? And I would argue not. It's the superficial, the tibionavicular, the navicular calcaneal that is really, you're
Yeah.
Yeah,
harnessing that area.
I
So just something to
I
think about.
no, I agree with you. But in a case like this, if you're locking up TN, subtalar joint, all the above, all you need to do is connect one of the medial mal to the construct down below, and it's all fused and corrected. So for an
Yeah.
extra 5 minutes, we can anchor down the deltoid and not have to worry that it might be insufficient, or at least it might prevent against some of that chronic subluxation that could occur over time. Brad said some of his patients are obese, but he lives in Wisconsin, so we know what that means.
Well, we know
You
that
guys,
deep prevents that external rotation of the talus, right? Which is a huge contributing factor to deltoid injury. So I think stabilizes it isn't a horrible idea, to be honest with you. And if it doesn't take that much longer, it's beneficial.
yeah, we're up against time. I think we could go for another hour or two because Flatfoot is all encompassing, but we're going to wrap it up for the sake of time. Thank you guys for joining us, Dr. Ortiz, Dr. Theodoulou, and partner Dr. Brad Abik. Thank you guys for joining us tonight. We appreciate your time.
Thank you, guys. Thanks for joining, Mike.
Oh, thanks for having me. I
And
wasn't
thanks,
expecting. I
Jeff.
was just
Thanks,
putting my
Brad.
little chat later.
No,
Excellent.
talk.
no.
Yeah.
You were huge on this paper, so I'm glad you were able to join us.
Happy to
That
be
was a lot of
involved.
fun. Appreciate you guys.
Yeah.
Thank you to
Thank you,
all the
guys.
other authors that were on the paper as well. We don't have
Yeah,
time
absolutely.
to mention them, but they put in hard work as well. So
There was an incredible crew. I was glad to be part of it. All right, guys. Have a great night.
Mike, thanks so much for coming up, man.
Oh man, thanks for inviting me on at the last second.
Appreciate
Truly
it.
appreciate it. Yeah,
Absolutely. Yeah,
Later.
that was awesome.
Okay. Thanks, guys.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.